We hope you like this week's edition of Optimal Anesthesia. The exciting field of endobariatric surgery is our focus today. These cutting-edge methods are revolutionizing the treatment of obesity by giving people who want to become healthy access to non-invasive options. The importance of anesthesia in assuring patients' safety and comfort during these treatments will be discussed, as will the evolution of this field. Okay, so let's begin. The history of endobariatric procedures is an exciting journey. These minimally invasive techniques have come a long way, offering new hope to individuals struggling with obesity. Let's take a quick look at how we got here. Endobariatric procedures have evolved significantly since the 1980s, with the introduction of intragastric balloons in the 1980s. Advancements in endoscopic techniques, such as endoscopic sleeve gastroplasty and primary obesity surgery endoluminal, have further improved the procedure. In the 2010s, there was a growing focus on refining existing techniques and introducing revisional options for patients who had previously undergone bariatric surgery. Now, let's talk about the primary endobariatric procedures. These are the first-line approaches for those seeking weight loss through minimally invasive means. The pose procedure is one of these primary options. It's essentially an incisionless technique that creates gastric plications. These plications reduce gastric volume, making patients feel full sooner. But what about the anesthesia side of things? The pose procedure typically calls for general endotracheal anesthesia, GETA. Why? Well, it's quite time-consuming, and there are specific risks involved, like the potential for intraprocedural bleeding. Then we have the endoscopic sleeve gastroplasty, ESG. This procedure is fascinating. It remodels the greater curvature of the stomach through full-thickness sutures, effectively reducing gastric capacity and delaying gastric emptying. For ESG, the choice is usually GETA, with full-thickness suturing. But do note, post-procedural pain can be a concern, often requiring a more extended recovery. Another option is intragastric balloon insertion, which uses balloons to induce gastroparesis for weight loss. The type of balloon used actually dictates the anesthesia approach. You can go with deep propofol sedation, monitored anesthesia care, MAC, for balloon insertion. But when it comes to removing fluid-filled balloons, GETA is the way to go, as they need to be punctured and deflated. Then there's the Aspire Assist device, which allows patients to aspirate ingested food portions from the stomach. This is suitable for individuals with a BMI between 35 and 55 kilograms per square meter. For this procedure, deep sedation is typically employed for both device insertion and removal. Last but not least among the primary procedures is gastric botulinum toxin injection, which involves injecting botulinum toxin into the stomach lining. This is typically performed under deep sedation. Now, let's take a look at the revisional endobariatric procedures. These come into play when patients have previously undergone bariatric surgery and need additional interventions. First up, we have TOR, transoral outlet reduction. It's used in patients who've had Roux-en-Y gastric bypass procedures and narrows the gastrojejunal anastomosis while reducing the size of the gastric pouch. This is another situation where GETA comes into play, along with endoscopic suturing. There's also ROSE, restorative obesity surgery endoluminal, which is quite similar to TOR but focuses on reducing the size of the gastric pouch. The approach here remains consistent, GETA and endoscopic suturing. Lastly, there's mucosal ablation, argon plasma coagulation. This procedure involves the application of argon laser coagulation to the anastomotic outlet. For most cases, deep sedation is sufficient. Just keep in mind that multiple sittings may be required to achieve the desired results. It's crucial to recognize that obesity isn't just about body weight, it has significant implications for airway management. The extra weight can lead to specific concerns. First, we have the issue of increased upper airway tissue. Excess adipose tissue in the neck and throat region narrows the upper airway, making obese patients more susceptible to airway obstruction. That's one challenge to keep in mind. Decreased airway patency is another concern. Reduced muscle tone and compliance in the upper airway, especially in the pharynx, can lead to partial or complete airway collapse. Airway patency is crucial for efficient ventilation and oxygenation. Then there's obstructive sleep apnea, OSA, a sleep disorder closely associated with obesity. Patients with OSA experience repetitive episodes of upper airway obstruction during sleep, and these episodes may persist during anesthesia, increasing the risk of complications. Last but not least, obese patients often have short necks and limited neck mobility, which can make it challenging to position the head and neck optimally for airway management. First on our list is the increased risk of airway obstruction. Imagine your upper airway as a narrow hallway, and now imagine trying to navigate that hallway with excess baggage. Obese individuals often have extra adipose tissue in their neck and throat areas, which can narrow the airway and increase the risk of partial or complete obstruction when they're in a supine position during anesthesia. Next up, we have decreased airway patency. All that extra fat can compromise the airflow through the upper airway, especially when the patient is anesthetized and muscles relax. It's like trying to breathe through a straw with a kink in it, not the easiest task. Achieving and maintaining a proper mask seal for positive pressure ventilation can be more challenging in obese patients. Think about it, excess soft tissue in the facial and neck areas makes it akin to trying to seal a leaking water bottle with your hand. It might require more pressure or the use of specially sized masks for effective ventilation. Now, here's a big one: difficult intubation. Obese patients often have shorter necks and extra soft tissue in the throat, making it quite a task to insert an endotracheal tube or visualize the vocal cords. It's like trying to find your car keys in a bag full of random items. Proper positioning is crucial for maintaining a patent airway during anesthesia. Think of it like setting up your favorite yoga pose, elevating the head of the bed and using pillows or ramps to achieve the perfect sniffing position. It's all about optimizing airway alignment for a smooth procedure. Another critical aspect to consider is the risk of obstructive sleep apnea, OSA. Obesity is a significant risk factor for OSA, and anesthesia can exacerbate it, leading to increased occurrences of airway obstruction and desaturation. Think of it as a snorer's worst nightmare when they're under anesthesia. Obesity can also mess with the mechanics of ventilation and perfusion in the lungs, potentially leading to ventilation-perfusion mismatch. This can result in low oxygen levels during anesthesia, and vigilant monitoring of oxygen saturation is crucial to intervene if needed. It's like trying to balance your checkbook. You need to keep an eye on your financial health. Did you know that obese patients may have a higher metabolic rate and oxygen consumption? Anesthesia providers must ensure an adequate oxygen supply and monitor oxygen levels to meet the patient's unique needs. It's like fueling a high-performance race car. You need to make sure there's enough gas in the tank. Lastly, obesity can impact the distribution and metabolism of anesthetic drugs. Providers may need to adjust drug dosages to achieve the desired level of anesthesia and avoid overdose. It's like trying to bake a cake but needing to adjust the recipe because you're using a bigger oven. In conclusion, when it comes to anesthesia in obese patients, it's like embarking on a unique adventure. Challenges like airway obstruction, intubation struggles, and the risk of sleep apnea make it a fascinating field in healthcare. Effective airway management and monitoring are the key to ensuring patient safety and the success of anesthesia in this special patient population. Obesity, a global health concern, touches every aspect of medicine, and it's no different when it comes to anesthesia. We'll explore how those extra pounds can affect the way we administer medications during surgery, and we're breaking it down to 5 key categories of anesthesia drugs. First up, intravenous anesthetics. Imagine you're about to undergo surgery, and the anesthesiologist prepares to put you under. In obese individuals, increased adipose tissue is like a sponge that soaks up anesthetic drugs. That means it might take longer to fall asleep and longer for the drugs to wear off after the surgery. So, anesthesiologists have to make some careful calculations to ensure you get the right dose, often based on adjusted body weight. Next, let's talk opioids. You've probably heard of fentanyl and morphine, right? In obese patients, these drugs can take a bit longer to kick in and stay active in the body for longer. So, when the doctor decides on your dose, they have to consider factors like adjusted body weight or lean body weight. We definitely don't want you experiencing too much pain or breathing too slowly. Now, the stage is set for neuromuscular blocking agents. These drugs help keep your muscles relaxed during surgery. But in the world of obesity, they can be a bit tricky. See, the extra fat can affect how these drugs are distributed, which, in turn, influences how fast they work. Anesthesiologists might have to adjust the dose based on total body weight or ideal body weight to make sure your muscles stay calm throughout the procedure. Local anesthetics, the heroes of numbing sensation, can also be affected. In obese patients, their distribution can vary due to the increased fat content. It might mean that an anesthesiologist has to consider adjusted body weight when determining your dose. They want to ensure that you're comfortable during and after the surgery. Lastly, let's talk about volatile anesthetic agents, the ones inhaled through a mask. In obesity, these agents might require some fine-tuning. See, your body's higher fat content can influence how the drugs are distributed, potentially affecting the depth of your anesthesia. So, your anesthesiologist may need to adjust the vaporizer settings to get it just right. But before we say goodbye today, we want to touch on the exciting medical revolution, endobariatrics. This innovative approach combines endoscopy and bariatric surgery techniques to provide effective weight loss solutions for those struggling with obesity. It's a game changer in medicine and brings hope to many. Now, let's discuss the critical role of airway management. In obese patients, airway management during surgery can be more challenging due to anatomical variations. Anesthesiologists must be well prepared for endotracheal intubation, which involves inserting a tube into the trachea to maintain a clear airway during surgery. Precision and expertise are essential in this process to ensure the patient's safety and oxygenation. Sedation is another aspect that needs to be finely tuned. Anesthesia providers may use techniques like nasal airway insertion and high-flow nasal oxygen therapy to optimize the patient's comfort and safety during the procedure. These advanced methods allow for better control of oxygen levels, providing an extra layer of assurance during surgery. In our upcoming episodes, we'll dive deeper into the world of endoanesthesia. If you found today's episode informative and thought-provoking, please share it with your friends. And don't forget to subscribe to Optimal Anesthesia for more intriguing medical insights. Thanks for tuning in today.